Thank you so much for taking the time to join us for this afternoon's webinar hosted by the North Carolina Medical Society Foundation and the North Carolina Medical Group Management Association. My name is Danielle Snyder and I'm with the North Carolina Medical Society Foundation. We're thrilled to have you joining us this afternoon. The Medical Group Managers Association mission is to maximize the value and effectiveness of medical practice leaders through educational programs, information exchange, networking, and professional development opportunities. The Medical Society's mission is to provide leadership in medicine by uniting, serving, and representing physicians and their healthcare teams to enhance the health of North Carolinians. We have enjoyed our collaborations with these monthly Lunch and Learn webinars we produce for our membership, and in each of our shared educational opportunities, we embody these two missions, this virtual meeting being no exception. Today's presentation is focused on health equity in context. This presentation provides a foundational overview and educational outlook of the principles of health equity, health inequities, health disparities, and drivers and determinants of health. The historic and contemporary context of these issues, barriers to help shape much needed discussion and conversations on eliminating those barriers, sharing resources, and building trust. Throughout today's presentation, you can submit your questions in the chat box, and we do plan to have time at the end of the presentation to answer your questions as well. We are recording this presentation and it will be made available to you after today's session on the Medical Society YouTube page. We will also be emailing out a link directly to you next week. Without much further ado, I would like to introduce our speaker today, Cornell P. Wright, MPA. Mr. Wright serves as the Executive Director of the DHHS Office of Minority Health and Health Disparities. He is a subject matter expert around the areas of health equity and disparities, minority health, and community engagement. Wright is an active member of the health community, serves various groups, organizations, and boards, including the Patient-Centered Outcome Research Institute, where he serves on the Clinical Effectiveness and Decision Science Advisory Panel, and the Southeastern Health Equity Council as part of the National Partnership for Action to End Health Disparities, serving as the co-chair to Social Determinants of Health Committee. He has received awards and recognition for his contributions to health from the National Institute of Health, Leukemia and Lymphoma Society, North Carolina Central University, and the National Minority Quality Forum. Thank you so much for being here with us today, Mr. Wright, and now I will turn it over to you.
So using plain language definitions, which are extremely helpful in the work that we do, health equity really speaks to the ability for all of us to have good health and well-being. Those unfair differences that exist and occur that prevent people from actualizing that, we call the health inequities. And the way we measure what we're seeing in terms of comparison and differences, those we speak about as the disparities in health. So when we look at African Americans and American Indians in this state that are dying 2 to 3 times higher due to complications of diabetes, that measurable gap or distance is what we call the disparity. Then we look at those factors that can greatly influence the way we live, work, play, engage, and worship. In many cases, those are what we call the drivers and determinants of health. And this is important because when we think about those influences to our lives and how they impact our health, they become very significant. And so some of the drivers and determinants of health that most often get kind of highlighted are things like environment, education. When we think about poverty, we think about economic situations. We're also thinking about safety. We're thinking about food security or the lack thereof. So violence also plays a role in the safety piece as well, education. And so it's so many different factors that can influence our health and well-being in the way we live, work, play, and engage and worship. One of the things that's so important that comes up as a driver and determinant of health that we don't talk about enough is that of trust. Trust is so important to the equation of what we're speaking about. And so when we think about the way we connect with people, the way we connect with systems, or the way we don't connect with people or systems, trust has a lot to do with that, or the lack thereof. And so we've seen a large number of people recently saying how they don't have trust in this or that. We've seen people not wanting to take vaccines because they may not trust all the information that they're getting or not getting. So we've seen how trust can play a huge factor in how people decide things. Taking it on even a more basic and granular level, the way we make our decisions usually is based off trust. If you want to take it to, the grocery store, you go somewhere, you pick up an item that you've always picked up because you have built a relationship with that company or that item, and you trust that it's going to work. And so you continue to buy that product because it gives you the results that you are looking for. Or, same thing with staying with a certain car company or brand. You are trusting your well-being. You're trusting your look. You're trusting them to give you what you're desiring in terms of the product that you purchase or the company that you patronize. And so trust is huge in our lives, but we don't talk about it enough. And so, of course, we've seen the issues historically in the context of, in especially communities of color, and what a term I'm going to be using called historically marginalized populations or historically marginalized communities. And I'll shorten it from here on out to just say HMP. When I say HMP communities, we're talking about historically marginalized populations and communities. And these are communities that are not just based on race and ethnicity, but also how people define themselves in groups. So that could be through sexual orientation and gender identity. It could be where people are placed geographically. So if we're looking at people in rural areas, and then our veterans, our homeless, our refugee, immigrant populations, or migrant populations, how that comes into the conversation. And then also our disabled communities, our deaf, our hard of hearing, our deaf, blind, our blind communities, people who have not always had the opportunity to get resources or seek services or have opportunities to do things as other organizations, other groups have had those opportunities. So, when we think about this concept of systems of unshared power that promote advantages for some and disadvantages for others, we're talking at its core about racism and racist systems that perpetuate themselves by not sharing power. And those systems of unshared power continue to play themselves out where people are advantaged and some people are disadvantaged. And so we're seeing this, as a part of the factor in terms of how people respond to certain items. And so in more of the medical health realm, we see a lot of this played out. And we've seen historically, people taken advantage of. We can go very far back in our history, just depending on how far back we want to take it, to see these things played out in medical experiments on people of color. a lot of the more popular conversation is usually around the Tuskegee experiment and the syphilis study, but more than just that has happened to people of color with medical experimentation. So we also have to look at the University of Cincinnati with the radon studies. You have to look at Henrietta Lacks and how her cells were used and repeatedly used without her consent in science and medical advancements, even to this day. You have to also look at sterilization and eugenics that happen in this state. You don't even have to go far, right here in North Carolina, and see how people's lives were utterly destroyed by sterilization in the eugenics cases. And then you also have so many more contemporary conversations where patients and families have been treated poorly by systems, of medical systems and healthcare systems, even if it's not as egregious as some of the ones I just named, but it still is important to make sure that we lift up and understand that people are going through different types of and levels of care or discrimination or different other issues that they have to face once they go to seek care. And that's a problem. So in hospital systems, medical systems, we've seen different types of labels given to patients. One of those labels that I've seen firsthand was labeling them as frequent flyers. And so this is when medical patients come in contact with medical systems at a higher rate. They keep, you discharge them and they keep coming back. For some reason, we have not figured out in a lot of those cases some root causes of what is making people come back. We also, in connection with that, or even outside of that, have seen a labeling of non-compliant or non-adherent for some of these patients. And I was, reflecting on a story when we were setting this meeting up about when I worked as a patient navigator at Duke Cancer Institute. We would hear that term a lot. Oh, this person is not compliant. This person is not adherent. They're not showing up for appointments. And so a colleague of mine, Valerie Worthy, who still works at Duke Cancer Institute in patient navigation, we put our heads together and said, I wonder if people are asking the right questions. So we went up to the schedulers and we said, we see a lot of these cases in the system that are saying, non-compliant, non-adherent, or, whatever the terms were to flag that people weren't showing up for their appointments or not adhering to maybe their regimens that were prescribed. And so we asked the schedulers, when this occurs, do we ask any other questions or do we just cancel appointments or whatever? So the schedulers they call, they cancel appointments, we cancel it, and then that's it. So we took that information back to leadership and said, hey, if we ask one or two questions, maybe we can gain some traction and save the university system or the medical system money. And so that question, pretty much, or those questions were, why are you canceling your appointment? And can we reschedule your appointment? And after kind of reviewing the cost benefit analysis of that process, it started saving the hospital system so much money because things in life happen. If you've been around this world for at least the past 2 years, then you understand what it is to have a certain type of normalcy in your life and then have that kind of turned upside down. And so as we think about what people go through, we have to be um, reminded sometimes that we are human and things happen in life that are beyond our control. Um, and so by just asking those two questions, we were able to really understand what it is that the problems were. Maybe people had a death in the family, maybe there was, financial issues. And as a patient navigator, my role was to um, figure out what the problems are and then find solutions for those problems to eliminate the barriers for people to care. And so once we started to figure that out, we had better relationship with people. We had better traction in the health system, and we were able to get people the care they needed by finding out what the issues were, and that also helps to build trust. But then you also get to understand that that is not the end all be all solution for everyone. There's no one size fit all solution for everybody, but it is a start. And so understanding what people's needs are goes a long way of building trust and having trustworthiness in how we practice care, how we practice health, and how we treat people. Not only just, in the medical sense of treating people, but in the normal sense of being a good neighbor to someone. That makes a huge difference. And so I know I've harped on this point a lot because all these things are important as we start to talk about wanting to build equity, wanting to give that opportunity for everyone to experience and have good health and well-being. One of the more important things that came out of those conversations is the ability to have patients feel heard and feel valued. And so a lot of times, many of us have been guilty of going into communities and planning already for communities before we've even met with them, and creating these interventions that are pre-designated to this certain community, and it may not be what they want or what they feel that they need. There's been many a day where I've gone in as a health educator to help a community, quote unquote, and they could care less about my pre-diabetes program. They could care less about my cancer screening program. They could care less about my hypertension programs or, my maternal child health programs, because to them, a lot of times it's about paying the rent, keeping the lights on, having clean running water, and then the ability to provide food on the table for their families. And so by reimagining the way we do health and healthcare, especially in this country and in this state, we can make a difference at really reaching root causes and having the ability to make important impacts. It may not look like the way we normally have done things. And so that ability to understand, one, what the barriers are, and then two, how do we overcome those barriers so that people can get to the point where we can do the health interventions and have more sustainable impacts on their lives. So important. And so some of the other barriers, we've seen that are not new to many of us, you know, that include the educational pieces, the financial pieces, the fear, the misinformation that can occur are not new to us, and also just the locations and where we live. Where you live could be a determinant of how long you live. So your zip code can be a predictor on your health outcomes, just due to what you have available to you, what advantages and disadvantages are, based upon where you are. There are a lot of places in North Carolina that are considered rural. We have 100 counties, at least 80 of them are considered rural. And that's significant because if you have, issues around inequities and disparities where you are from, and then based on how you identify, you have more of an issue, then you're compounding an issue on top of an issue. So if you're within a historically marginalized population or HMP community, and you live in a rural area, then you could have, disparities and inequities that are, 2, 3, 4 times higher than you would see in more of the urban centers that exist. But even in those urban centers, you even have pockets of poverty and pockets of rurality that exist. So just because you may live in Raleigh, just because you may live in Durham, Chapel Hill, Carborough, or you may live in Charlotte, Greensboro, or you may live, somewhere that's very populated, even Winston-Salem, for instance, there are still pockets of poverty and rurality that exist. And that is where we also have to divert our attention. So one of the things I wanted to share with you was that this work of advancing equity is not new. This work has predated me and will exist even after I'm gone. But it's important that right now we're starting to see so much traction and highlights in terms of what is needed to be done. And so in North Carolina, when COVID hit, our leadership here at the Department of Health and Human Services was able to help us create a mechanism to be mindful of these populations that I'm speaking about. And so what we created was the Historically Marginalized Population Work Group. And so this is a collection of all types of partners, whether it be from state government, from academia, from local health departments, to community-based, grassroots, faith-based organizations, you name it. It's health, other health systems and agencies and organizations are all a part of these groups. And so when we first started, it was around giving a chance for people who didn't necessarily have that opportunity to be connected to the resources properly or effectively in these spaces, especially around COVID. And so we wanted to get people connected initially to testing and PPE, and that translated into evolving into having people getting connected to vaccines. And so when we looked at the vaccine rates initially, it was very similar to what we saw with testing initially. The people with the more advantages were able to be connected to those resources, where the people with the disadvantages did not always have that same opportunity. And so through the work of our Historically Marginalized Population Work Group, we broke everything down into 6 main pillars. We had one for testing, prevention, contact tracing and case investigation. We had wraparound services, which included isolation and quarantine supports and services. We had behavioral health, and then procurement. And it's always interesting when I say procurement, because in order to do a lot of the work that is done, we have to make sure that we are funding people and organizations that can help penetrate communities across the state to have a wider reach and impact. And so as we have been evolving to focus on not just COVID and get to more the advancing of equity as a part of the larger strategy, and back to our normal works, we've included some evolved work streams. So prevention has stayed the same. We have upgraded testing to not just be testing, but testing and screening. We have taken 3 of our work streams and combined them. So what used to be contact tracing, case investigation, wraparound service, and behavioral health have been connected to each other. And we created one larger work stream called community engagement. We created a brand new work stream called um, health equity education and empowerment. And this kind of looks at the materials in which we use to train folks and educate folks, whether it be vaccine 101, whether it be health equity 101. We also even have a subgroup within that that works with students at the high school and college levels called our HMP Academy. And we actually have 2 interns, 2 student interns, one that's in high school and another one that just graduated high school, is about to be a freshman in college, that are working with us and other students that help build out this HMP Academy. So that work has been phenomenal. And then we changed the name of procurement and the scope a little bit more to be economic opportunity and employment equity. And so not just looking at how we fund people to do a lot of this work or sharing those funding opportunities that exist, but also getting more diverse, equitable, and inclusive representation in the workforce, and sharing out, the information as in the most simplest form, sharing out information that goes out when there are job announcements, so that the pool of applicants can be more diverse and more equitable and inclusive in its approach. And so as that work continues, it's so important that we don't lose focus on how we're still here. The reason why we're still here is because vaccines have really changed the game in this COVID-19 process. And being able to go into communities and educate those about vaccines has been extremely important. It may seem weird to some of us because we hear it all the time, but there are so many groups of people that still have questions, who still want answers, and being able to provide those have been able to save lives. And so with this new Delta variant that has been running across the country and taking lives and putting more people in the hospital and raising our rates back to where we've been seeing them, we still have to find ways to protect ourselves and those around us. And this is the part about being a good neighbor that's so important. Being able to still wear our mask, even if you are vaccinated in public. Still, having that distance, that physical distancing. Washing our hands should always be a preventive measure that we do every day and every time. But then also helping others to be vaccinated, helping them schedule their appointments, taking them to appointments if you can, because it's so important to understand that not everyone is eligible to be vaccinated right now. I have a 10-year-old child who is not, eligible. So we have to make sure that she's safe and protected, and then the people around her and the people around us have that same protection. As we get into more of the conversation around transformation, we need to make sure that people understand what these differences are, why it's important, what are the changes, and how does this affect your ability to receive health and health care. And so working across the table with our different partners to help educate and inform our residents, our community members, and even some of our legislators on why it's so important as we move into this transformation space. And even the way we fund people has changed significantly in a lot of cases, of going from, the normal regional systems that we had in place to now this new transformation 6-region system. And so we lean on our partners to help, make the change in communities, to help share what communities are providing as feedback and input in different cases, so that we can be attentive to the needs of the people that need us the most. One of the things I like to share, and I'll stop soon and take any questions that we may have. But one of the things I like to share is that health equity is not the sole responsibility for one person or one agency, but it is the collective responsibility for all of us to know better, do better, and help others be better. So with that, I thank you for having me, and I will stop right there.
Thank you so much, Mr. Wright. That was a lot of really great information. I do want to open it up. If anyone has any questions, we do welcome you to turn on your camera and come off of mute if you would like to join the conversation. If you have any questions, you can definitely put them in our chat box as well. We can make sure we get those answered. We'll give it just a second. I don't see any right here at this moment, but I do just want to give it a second and see. Sometimes it takes people a minute to be able to hit all the buttons. So again, if we have any questions, please feel free to come on camera, come off mute, or type your question in the chat box.
And then if you can, I'll ask a question of the group. What is it that I should be taking back from this meeting to share with leadership at the state level that you would want them to know that's important, not even just leadership, but also the communities in which we serve across the state? What are some things that we need to be sharing with them from your perspectives as well?
Looks like we've got Alexander, if you wanted to come up and say something.
Oh, hey. Well, I was going to ask a question, and then Dr. Wright, you asked a question of us that I don't have an answer to. I was curious about the HMP work groups. I was curious as to where they were going and how how they were going to be used to advance toward health equity. I was wondering if you could say a little bit more about those.
Sure. So the HMP Work Group has the different work streams as I talked about. So we have a huge meeting. It's so funny because I'm usually there right now. We have a huge meeting weekly at 12 o'clock called our HMP Connections meeting, where we have like different guest speakers, kind of like this format here, that we also bring people together to talk about the different areas around health equity. That work group piece is embedded in my office now. So the work of our office is synergized with what we're doing in terms of the overall health equity strategies and approaches from my office. Is like connected. And that's why we changed the work streams to not just focus on COVID, but we wanted to make sure there was synergy around our bigger, broader health equity strategies and approaches. So it connected back to people's everyday work. When I first got here about 6.5 years ago, one of the main things that we did up front was create a whole learning series called the Health Equity Lunch and Learn series. And so we used that to kind of help normalize the work of health equity in everyday spaces. So you would have people from all over, because they're open to the public. We would have people from all over who were connecting to these lunch and learns to understand if you worked in cancer, if you worked in maternal child health, if you worked in social services, if you even worked in something like finance, how that is to the work of equity and advancing that. And so as people start to understand why this is important, then it becomes a part of their everyday lives and not just something that group over there does that. And so our HR department has even taken a step further and added some components of diversity, equity, and inclusion into our performance reviews at the state level for DHHS, which is also important because now I have always had those measures in my personal performance reviews, and my staff has, but now it makes it not just about one group or this collection of individuals that do this, but it's the combined force of us all to see equity in our work. And that's what makes it really more important as we become to normalize why we need this. So in terms of the work streams, so they meet weekly. And anyone can join these work streams. If you're interested, you can, I could send the information and people can, look at the work streams and how they're kind of defined and say, hey, I want to plug into that. Or even if you just wanted to just sit in on one and just hear how stuff is being played out or provide input or insights, those are definitely something that we could share that we'll share with the group with that link. I hope I answered your question.
Yeah, thanks. Please do share the link.
Yes, sir.
Yeah, we can definitely make sure to spread that information around. Looks like we've got Keon Lewis up next, and then I have a question that came in the chat after you, so I'll let you take that off, Keon.
Hey, good afternoon, everyone, and thank you for your information, Mr. Wright, and definitely appreciate that. Excuse me. So in reference to the areas or the aspects of the community that you ran into some of those barriers with, and that they weren't too cognizant of the programs that you had about diabetes awareness and those issues, do you find yourself going back to those same communities, or do you find other ways and innovative ways to make sure you're relaying that information and that they're aware of those resources that you're able to provide?
Great question, and it's a yes and. So we go back and we also find ways to connect not only to the people initially that we connected with, but even other members of their family, members of their community, younger generations. Like, we have to be innovative with our approaches and strategies because one size does not fit all. And so this is part of why we have the HMP Academy, is to reach out and get the voice of the younger people, especially like during this pandemic. It's been important to have that voice and have it heard in a way that's like valued and respected. Because if we're honest with ourselves, we're not as young as we used to be. And if we think back far enough, I don't know how far it is for you, but I know how far it is for me. We can remember a time where we felt unheard. And even in like our adulthood, we can feel that. But it was really more pronounced as we were younger, and people would be dismissive of us. I think we've been trying to change that narrative in the space of what youth have to offer. Because when the age ranges went down to 12 and up for Pfizer, it changed everything. And so the way I would reach out to a 60-year-old person is not the same all the time that I would reach out to a 15-year-old or a 12-year-old. And so having that mindset of understanding who influences someone of this age. I mean, I have a 10-year-old daughter, but we kind of listen to some similar music, not all the time. I think I've messed her up, and I'm sorry, I'm gonna take a little privilege here. I messed her up a little bit because I turned her on to like 90s R&B. And so now she can't go to sleep unless she's got some 90s R&B playing in her room. So my daughter's she's a little different.
Good music right there. That's good music.
Yeah, beautiful music, beautiful music. But not every child is going to be that way. And it speaks to exposures, right? If you're not exposed to information, if you're not exposed to different things, you won't be made aware of it. And so what we want to do is expose younger generations to information, but in turn, expose older generations to younger generations and their preferences. Because if you really look at this thing in its whole, the people who are graduating or have graduated from high school are your new voter base, right? They're your new influencers. They're going to control this world. And based on how you treat people is how they're going to treat you. So there's an old kind of context about, be nice to your children because they might put you in an arrest home one day and just forget about you. And so it's an interesting concept, because if we are very mindful of how we treat younger generations, it's really going to prepare and propel them moving forward. If we're building up and encouraging leadership, then it's going to we're going to reap benefits from that in the future. But in order to have a future, we have to hear from them to understand where we need to go. And they need to understand from us where we've been to have that kind of symbiotic relationship.
Thank you.
Thank you.
Very well said. So next question that we have in the chat is from John. What outcome measures are common use for health equity work?
Whew. How much time do you have? It depends on what you're measuring, right? So a lot of times the more basic level of what we're looking at is connected to the outcomes that we see based on an issue or a disease, or what's the prevalence, what's the mortality rates, morbidity rates, those things, which is not always the best measure. We need to start getting more into accessibility measures, like what do people have access to? And then, when we measure, and this is interesting, because when we measure access, we also need to be able to measure the assessment. So it's one thing to get to care, but it's also another thing to tell me how that care was given to you and understanding. So what am I saying? What I'm saying is, if I get to the doctor and the person at the front counter is very rude to me, I'm going to treat this like I treat any other interaction. Is I'm going to reconsider coming back to this establishment or not based on how I felt, or how I was treated. And so if you have a barrier like that, it needs to be heard, it needs to be pronounced. So getting the access is just one part of the puzzle, but being able to assess the level of care you've gotten is a whole nother world. Because as I go to different appointments, literally yesterday, I was at a doctor's appointment, and they always ask you that question of, oh, so what do you do? So I try to be slick with it and say, well, I just work in healthcare. Oh, well, what do you do in healthcare? Like, what's your specific job? And I'm like, okay. So I'm the executive director of the North Carolina Office of Minority Health and Health Disparities out of the Department of Health and Human Services with Dr. Minico serves as our secretary. And they were like, okay. So then the whole thing changes, right? And then what they don't know is that I also have experience in working in two different hospital systems. I'm actually trained in EPIC at UNC Health and at Duke Cancer Institute. And so it's always different, because then I start talking in hospital lingo in abbreviations, and then that turns into a whole nother conversation. So it all depends on people's perceptions of you, right? But what I've seen firsthand is if people think that you're not listening, or if you're like poor, or you're a drug seeker, or that we had so many problems with people that have issues with sickle cell, that when the opioid crisis kind of hit, they weren't getting treated properly because people thought they were faking their pain, because there's this preconceived notion that certain members of the population, including Africans and African Americans and Black people, have a higher pain threshold and tolerance for pain, that, oh, you can take it. And then, so when you look at the numbers of the opioid crisis, in a lot of cases, it didn't affect as many prescription opioids. It didn't affect as many African Americans and people of color as much, because a lot of times we weren't getting prescribed. In that same breath, in North Carolina, the highest numbers of cases of deaths and incidents we saw in our American Indian populations. So even in, the one way of saying it, and then another way of looking at it, we were seeing both sides of the fence. We weren't getting prescribed, because they thought we were drug seekers. But then another HMP population, American Indians, were having more issues, more deaths, and then any other population, including the white population, by percentage, because they, were getting more affected by this issue. And so I said all that to say, there's so many things that we measure. One way we measure some things and putting it together is we created a health equity report in 2018. And now we're taking what we learned from COVID and creating these health equity dashboards. And so if you go and look at ncdhhs.gov, you'll see that for COVID, we have these public facing dashboards that exist. So we're trying to create a whole new system now that you can look at trend data, data 3 to 5 years at least, so you can see where the trends are. I mean, you could do a lot of micro version of trend data for some of this COVID stuff, but we want to make sure that people can see where the issues are and where we need to put resources and pivot in some of the approaches that we currently have. Hope that answered a little bit of that question, but I know I can go on a tangent if I'm not careful.
It's like, I had someone once say, it's like trying to measure running water.
That's a good one.
Yep. So we have another question here from the chat. Assuming everyone has implicit biases, should we encourage healthcare providers to get cultural competency trainings?
Yes, because bias is interesting in its conversation in itself, but also macro and microaggressions can be interesting within itself. And some of the things that are those type of macro and microaggressions, most people don't even understand what, that they are. So asking a woman if she's pregnant, planning to have kids, or asking a married person or non-married person if they're, trying to procreate could be a microaggression, and depending on that situation could be a macroaggression. You don't know if people have dealt with in their life, you don't know if they've had miscarriages, you don't know anything to that sort normally. And so just being that intrusive could cause other issues, could cause triggers, could cause trauma to be revisited. And so we have to be so careful of how we talk to people and with people. So yes, implicit bias training, cultural competence, cultural relevant, cultural awareness, cultural sensitivity, all those trainings are very helpful, because when we look at how a lot of people practice care, they say I practice colorblind care, meaning that they don't see color in the care to provide. But I need them to see color, because you may need to treat me differently than I've been treated or I need to be treated. And so that is an important conversation that we're not saying things that are insensitive. We also need to understand the cultural differences that may occur based on how people identify. Some people in some cultures have different norms where people can't look you directly in the eye, or people can't touch you. And we need to make sure that we have consent when we do things, when we're touching people or we're getting in their spaces. So there's so many pieces that are connected to this conversation. It is important, and we need to start it as early as possible. I talk to my daughter all the time. My wife and I talk to her all the time about I literally had a conversation with her yesterday before she went to camp about protecting her space. She is the master of her space. And I said, you got one job. What is it? She said, it's protect my space. And I said, yes, nobody should touch you. Nobody should be forcing you to have hugs or give kisses. Not even mommy and daddy. You don't have to kiss or hug us if you don't want to. If you're not feeling it, that is fine. We can do air hugs, we do air kisses, or we can do nothing at all. But we have to have these important conversations as early as possible to not only protect ourselves, but protect our youth and those that are around them.
Absolutely, wholeheartedly agree. And from my personal experience as well, we've been very lucky at the Medical Society that we have had a few trainings with REI, the Racial Equity Institute. And I am ashamed to say, growing up, my mother is a 7th grade social studies teacher, and I got into, the Racial Equity Institute training, and there was so much that I didn't know that I didn't know. And it was hugely eye-opening just from a basic historical perspective of some timeline things that, really brought a lot of light to some stuff that I just had no idea about, and changed my understanding and ways of approaching things. So I wholeheartedly agree that as much training and as much exposure to this information that we can have, we can only get better and better at how we interact with each other. So thank you for that.
And what I love about those trainings is that they encourage you to keep coming back, because as you probably can attest to, and as I can too, bro, being in those trainings multiple times, you hear something different each time.
Yeah.
There's some things, like when you first go through it, you may be so shocked that you're just numb to all the information that they give you. I think one of the things that stood out for me is being from a military household was the information about the GI Bill and how that was used, you know, to help advantage and disadvantage people at the same time. And so just getting that better, broader understanding is so important. So I totally agree with you.
Yes, knowledge is power.
It is.
We've got a few minutes left. If anyone else has other questions, again, please feel free to come on camera, unmute yourselves, or type that in the chat. Today has been a really great conversation with some really amazing information. Looks like we've got Chad. Here we go, Chad. I'll turn it over to you with your question.
Yeah. Hey, Mr. Wright, how are you doing? Thank you so much for your talk today. I'm a genetics doctor. I work out in the western part of the state, and I've been involved with leading a group through kind of Department of Public Health. I don't work for the state, but we sort of created this group to try and just improve how genetic services are provided to people in the state, and with education and access, and then thinking about kind of a data, kind of epidemiology aspect to it. But and so I've been trying to incorporate a lot of kind of health equity discussions in the work that we do. And I just was wondering if you had any specific thoughts about, in the genetic space, things to think about for us as far as, you know, what we'd like to try and do moving forward. I mean, I 100% agree with you. A lot of the, you know, the things that you discussed as far as prior examples of where I think people have marginalized populations have, you know, been taken advantage of, are unfortunately do involve a lot of genetic stuff. And so I definitely have some sensitivity towards that, but would just like to know what your thoughts are regarding that.
Yeah, and this is, I guess this kind of hits home for me. I just took a genetic test for one of the, just kind of find an understanding or some stuff I've been dealing with medically, personally, and there were no significant findings. So I thought that was interesting, because there was a finding, but it wasn't for what they were looking for. But they said it wasn't that, you know, it wasn't anything crazy. So I always, you know, think understanding genetics better can be beneficial to a lot of us. So there apparently was some type of mutation somewhere that they did see, but, you know, I think a lot of us don't just fully understand the role genetics can play. And this is not just, you know, this is general population I'm talking about. Like, so, and we don't fully understand how genetics play in our family histories and things of that nature. So the basic understanding of that can be very helpful if you all were to come up with a very plain language kind of discussion presentation that could be shared and duplicated. I think that could be very helpful in this conversation of showing the importance of why genetic testing and the coding and all that is so important to really understanding disease and other health issues that occur. When I was at Duke doing patient navigation, that was one of the things that we had as a trigger question of, like, we had family health history, but then we also had a section that could trigger a handoff to a genetic counselor in different cases, because we were doing screening for cancers at Duke. And so I've always seen the value myself in this world to have more information about genetics, and have been very involved in researching epigenetics, and have used some of those cases in a lot of presentations to understand the ultra stress hormone that can be passed down from offspring by the overloading of cortisol in people's bodies, and how it's not broken down properly, and how that can lead to other chronic disease and illnesses that get passed down to offspring that can continue to have that as an issue, especially when you look at the cases in the epigenetic studies that involve Holocaust survivors and how that ultra stress hormone was passed down to their offspring and what that does to the body and the stress and disease that it ramps up. So I've personally always been in kind of involved in wanting to know more and learn more, and it's kind of one of my, I will say, a side fixation on like I need to know what I don't know, and but not everybody's like me, so I'm kind of weird in that aspect. But I do want to make sure that when I'm passing things down to my child, if it's something that's already in me that could be in her, and having that understanding, because if I can understand it better, it can make her interventions, if she needs one, a lot quicker. And I think in our communities, if we have that understanding of knowing, I think a lot of times many of us just don't want to know it all. But I think if we have that understanding of how genetics plays a role in helping to mitigate issues and identify them, and then creating the proper treatment plans to save lives, I think having a better basic understanding of that could be so helpful. And then that helps improve equity, because then we're leading more people to seek services, to seek care, and then making more of an important impact on their lives and their family lives.
Great. Thank you. I really like this HMP toolkit. I was looking at that. I'll look to see how we can include that in some of the things we do. That's really good.
Definitely. And then I just signed off on the edits yesterday. So we're going to be actually putting out a newer version of it. So stay tuned, and I'll make sure we send that out to you all when the link is ready.
Great. Thank you so much.
No problem. And what he's talking about is we have a historically marginalized population toolkit for provider engagement, and on our website at ncminorityhealth.org, you can go and look at it. It's on the front page on one of the carousel pieces, and you just click right on it. And you go to our resource page and do the same. But it should be on the front page, maybe like the second spot that you could use. But yeah, this is a great toolkit, and we're using that to really engage with providers on all levels to really create partnerships with your local groups before you need to create these grant opportunities, or there's a pandemic, or there's an epidemic, or there's a natural disaster. Before you need that, if you're meeting with these groups already, you don't have to go reinvent the wheel.
Wonderful, great resources there. Thank you again for pointing that out. We are at the top of the hour. So I would like to thank you again, Mr. Wright, for taking the time to join us today, for giving us all of this fantastic information. Definitely eye-opening. As a reminder to everyone, we did record today's session, so we will be posting that both on our YouTube channel, along with sending a link out to you all. And as there were a number of other resources and links mentioned, and we will be sure to get those out to you as well. Thank you all for taking the time to join us today. We hope you have a wonderful afternoon. And as always, stay safe and stay healthy, and have a great day. Thank you so much. Bye-bye.